So we are starting with the semi-finals of the pre-paper session on cornea, and we'll now be starting the presentation. So we call upon the first speaker, the second speaker, and then Shalini Singh will repeat her presentation, which she has done now for the semi-finals.
Okay, so we start with Dr. Rakhi Kusumesh. Uh, for her paper on miltefosine related keratitis, clinical characteristics and management.
I'll be presenting on miltefosine related keratitis, clinical characteristics and management. I have no financial interest in the subject matter. Miltefosine is a drug that is originally developed as anti-malignant drug. It has been recommended by WHO to treat all types of leishmaniasis since 2002. And since that time, it is the first and still the only oral drug that can be used to treat Kala-Azar and its sequelae, that is dermal leishmaniasis. Kala-Azar, as we all know, it's caused by Leishmania donovani, and in 10 to 20% cases of apparent successfully cured cases, they develop post-Kala-Azar dermal leishmaniasis. And that is a potential source of Leishmania infection, and it is characterized by skin rashes. The prevalence of this PKDL in Bihar is 4.4 to 7.8 per 10,000 population. So the recommended doses of miltefosine for PKDL is 100 milligrams per day for 3 months, that is 84 days, with some uncommon adverse reaction like mild gastrointestinal symptoms. However, there are recent reports highlighting some serious corneal complications in patients receiving miltefosine. The lacuna of literature is that all the cases were documented with a clinical impression about the finding of miltefosine keratitis. They have shown the varied presentation from Moeren's ulcer to scleritis, and little is known about its clinical course and its management. So in this paper, we discuss the diagnostic clinical features, progression, and management of miltefosine-related keratitis in our 6 patients. This study was conducted retrospectively from 2018 to December 2021, including 6 PKDL patients receiving miltefosine, and the study was approved IEC, and written informed consent was obtained. The evaluation included complete medical history focusing on the drug used to treat Kala-Azar and PKDL, documentation of dose and duration of treatment, and the onset of treatment after initiation. We also performed the casualty assessment of adverse drug reaction to miltefosine by WHO UMC criteria. We worked up all cases of keratitis, including their size, location, pattern, depth, and presence and absence of epithelial defect, hypopyon, corneal sensation, and edema. And laboratory evaluation included the smear examination and culture, and PCR to detect the presence of LD bodies. RK39, which is a serodiagnostic test performed in all cases, and a skin biopsy to confirm the PKDL again. So results of our 6 patients. First case was of bilateral keratitis. He was receiving miltefosine for 48 days, and he continued taking this drug for another 17 days after appearance of ocular complaints. On the day of presentation, the patient had ring paralimbal full thickness infiltrate with presence of hypopyon. And since this was our first case, we didn't start steroid on the day 1, and we waited for the microbiological results. Until then, we started the high fortified antibiotics, and within 2 days, the ulcer progressed and involved the central cornea, resulting in corneal thinning, and for which patient was operated for penetrating keratoplasty. And after the result came negative, we started the oral and topical steroid, and left eye responded very well and resulted in 6/12 vision. Another case was also of bilateral keratitis, and this patient was receiving miltefosine for 35 days, and he continued taking for another 20 days this medication after ocular complaints. And this was a very classical picture. Patient presented with the ring paralimbar infiltrate rapidly extending to the central as well as the circumferential part, and for which he was operated for PK. And left eye responded with the topical and oral steroid, and giving a avascular scar within a period of 4.5 months. The rest 4 cases of 6 cases, they were unilateral keratitis and they had a history of miltefosine intake from 38 days to 65 days. And one thing was common in all that they stopped miltefosine by their own just after feeling the ocular problems. So they responded very well to topical steroid and attained good vision in a course of 3 months. So in results, the ocular symptoms were common: pain, watering, photophobia, diminution of vision, and there was a common pattern of keratitis in all the patients, like ring-shaped, full thickness, paralimbal infiltrate with the edema and hypopyon. 2 cases who continued taking the drugs even after appearance of ocular symptom, they had bilateral keratitis, and 4 patients had unilateral keratitis. The laboratory test, smear culture, PCR were negative for microorganisms, while RK39 and skin biopsy were positive. Management, discontinuation of miltefosine and initiation of corticosteroid therapy were the mainstay, and casualty assessment by WHO UMC criteria showed probable association between this keratitis and the miltefosine in all the patients. So we found a consistent pattern of keratitis and clinical course in all the patients who were receiving miltefosine, and on the basis of our result, we could divide miltefosine related keratitis into 2 stages. Early stage where the ring peripheral infiltrates were present with the intervening clear zone between limbus and the lesion. And in advanced stage, the infiltrates extend both centripetally and circumferentially to involve the center and the limbus, and the ring lesion evolved into a ulcerative keratitis. So its mechanism of keratitis in patient receiving miltefosine is not very clear, but drug might be directly toxic to ocular tissue. And this development of keratitis may be of an autoimmune response. So management of this case can be suggested by stopping the miltefosine, excluding the infectious etiology, initiating the corticosteroid as early as possible, and differing PK for complicated cases. So this study indicates that prolonged use of miltefosine might cause keratitis that resembles infectious keratitis. Early diagnosis with discontinuation of the drug and initiation of corticosteroid are key to successful management. And this study also emphasized the need to strengthen the pharmacovigilance program in endemic areas that monitors this serious complications. And patient receiving miltefosine should undergo periodic ocular examination by an ophthalmologist. These are my references. Thank you.
You have noticed,
In
apart
these-
from keratitis?
No, in these patients only infiltrates with the intense conjunctival congestion, and all the symptoms like pain, watering, photophobia were there. Apart from these, I didn't find any significant finding.
What was the average the duration of miltefosine and the presentation?
In my series, it was 48 days.
48 days.
48 days.
So it takes quite a bit of drug to cause this.
Yes, every
And,
day they were taking 100 milligrams.
Okay.
And
So did you calculate any accumulated dose of the drug which can lead to, like we calculate for hydroxychloroquine, right?
Yes.
That cumulative dose, I will say
yeah,
rather.
we wanted to
So,
do that,
yeah.
but the facilities were not there.
No,
to calculate.
the just a mathematical calculation, like if patient is taking 100 milligram daily.
Okay, cumulative
Yeah,
dose
cumulative
for
dose,
48
yeah.
days, so you can say that
Yeah. So was it correlating for all the patients, the cumulative dose, or the dose was given same to all the
yeah,
patients?
same to all
Same to all
patients,
the
because
patients.
everyone was more
Yes.
than 25 kgs. And if there is a recommended dose, 100 milligrams per day, if the patient weight more
Okay.
than 25 kgs. And if the patient is less than 25 kg, then the doses will be half.
And what was the histopathological finding in buttons you excised?
Yes, we did histopathology in 2 patients where we did PK. And except for intense inflammatory reactions,
Was it neutrophilic infiltration or lymphocytic infiltration? I mean, the neutrophilic, right?
they were neutrophilic, but not exactly these type of finding. Like we were looking for some leishmania, some LD bodies, like thing, but we didn't find any conclusive finding.
Okay.
So did it begin like a stromal, sterile stromal melt which got secondarily infected? What was your?
Yeah, actually, we wanted to rule out that only before starting the steroid. So we did microbiological examination in all the patients, and we didn't find any infective microorganism in all the patients.
So you recommend screening what? After starting the drugs, 3 weeks after starting the drug, you recommend screening
I
them,
would
or
recommend because every patient, like I showed you that unilateral keratitis, they stopped the drug immediately. So, and they recovered very well and they didn't require
right?
even PK.
But what is the
and
duration? 3 weeks, 2 weeks,
I would suggest
4
that
weeks?
1 month.
1
because
month,
Average
4
is-
weeks, yeah.
Average was 48 days. So I would
Right.
suggest after a month, if meltefosine is continued,
Right.
then better to is screened, get a good screening by an ophthalmologist. And it needs a good pharmacovigilance also.
Any other question?
Thank you.
Thank you.
Thank you so
so much.
Next, we call upon the second winner, Dr. Pinkal Shiroya. The paper is on to analyze the long-term outcome of deep anterior lamellar keratoplasty in pediatric keratoconus.
सुबह वाले सेशन में इसमें ना ये ना
Good afternoon, one and all. I am Dr. Pinkal Shiroya, and I'm going to present on long-term outcomes of deep anterior lamellar keratoplasty in pediatric keratoconus. As we all are aware that pediatric keratoconus is aggressive and rapidly progressive in nature, and the keratoplasty in pediatric keratoconus is always challenging because of lower scleral rigidity, general anesthesia, suture-related complication, graft rejection due to stronger immune system of pediatric patients. Deep anterior lamellar keratoplasty was the preferred procedure in our group. Lacuna in the literature is limited number of subjects, includes wide range group of age. Outcome includes several other indications, not specifically keratoconus. The aim of my study is to analyze the long-term outcome of deep anterior lamellar keratoplasty in pediatric keratoconus. It is a retrospective study of all the keratoconus patients less than 18 years coming to the cornea clinic of Arvind Eye Hospital, Coimbatore in a time span of February 2008 to December 2019. All the patients underwent pre-op evaluation, slit lamp examination, visual acuity and refraction and topography. The surgical technique used in our study was big bubble technique, and 0.25 mm oversized button was sutured with 10 nylon. As a post-op regimen, topical prednisolone was given in tapering doses initially, and then was later shifted to loteprednol and cyclosporin. This is how we are going to look into our results. 221 eyes of 185 patients underwent DALK. Mean age group was 6 to 18 years. In our study, 71% male predominance was seen more and left eye was operated more. The mean follow-up was from a range of 6 to 130 months. The most common comorbidity associated in our study was vernal keratoconjunctivitis. 39.3% of the patient had. Corneal apical scars were found in 6.65% of the patient, and deep scars in ASOCT was found in 1.3% of the patient. On comparing the visual outcome, the mean uncorrected visual acuity showed the improvement of 0.51 logMAR unit, and the best corrected visual acuity showed the improvement of 0.48 logMAR unit. On coming to refraction, the spherical component showed the tremendous improvement of 5.37 diopter, and cylindrical component showed the improvement of 2.38 diopter. Similar results were found in keratometry. Keratometry showed the improvement of 9.56, and SIMK showed the improvement of 3.35. On coming to the final vision, 80% of the patient had visual acuity better than 612. If we compare it with the other study like Arora et al., which showed the improvement of 45%, Patel et al., which showed the improvement of 86%, and Fizi et al., which showed the improvement of 84%. Surgical techniques, big bubble was successfully achieved in 66% of the patients, and in whom where we could not achieve big bubble, either patients were dealt with hydrodissection or manual dissection. If we compare the big bubble achievement with the other studies, Fizi et al. showed 75%, Nuxchan et al. Showed 77% and Arora et al. Showed 80%. But all this study included adult patients as well. On coming to the intra-op complication, DM perforation was noted in 15.39% of the patient, and 20 patients which had DM perforation had double AC and which were treated with rebubbling. On coming to post-op complication, the most common post-op complication is glaucoma. 14.9% of the patient had glaucoma. 30 patients were treated with anti-glaucoma medication. 2 patients were treated with laser trabeculoplasty, and one patient was treated with TRAB. Second most common post-op complication is cataract. 5.7% of the patient had cataract in our study. The commonest type of cataract found was posterior subcapsular cataract, and the 5 patients which underwent rebubbling had cataract as their post-op complication. The third most important post-op complication was delayed epithelial healing, which we saw in 20% of the patient, and 2% of the patient had non-healing epithelial defect and were treated with Botox. If we talk about the suture-related things, suture removal was initiated by 7 months in our study and was completed by 29 months. And 49 cases underwent replacement in and around 3 months. Graft-related complications, 13.12% of the patient had vascularization, which includes superficial and deep. 9.5% of the patient had infection, that is Streptococcus pneumoniae. And 6.67% of the patient had graft rejection, and it was treated with topical steroids. If we compare the fellow eye management of all 221 patients of eyes who underwent DALC, other eye was treated with C3R, which was treated with, number was 48.87%. DALC was 10.86% where patients were treated with DALC, and 2.71% of the patients were treated with PKP. If we compare the VKC and non-VKC group, we could find that in VKC group there was a delayed epithelial healing, vascularization was seen more, and graft rejection was seen more as compared to non-VKC group. These are the review of my literature, and hence at the end I would like to conclude my study. DALC is the most effective technique for pediatric keratoconus with good visual recovery and graft survival. DALC can be associated with unique complications like DM perforation and double anterior chamber, and Werner keratoconjunctivitis needs to be addressed to avoid the complications in pediatric keratoconus. These are my references. Thank you.
So did you observe that the growth of the keratoconus has stopped before doing DALC?
Pardon, ma'am?
See, in progressive keratoconus, if you do DALC, the chances of complications are more. So in pediatric groups, which level of keratoconus, which grade of keratoconus you took for
Mostly
surgery?
we chose the advanced keratoconus patients for doing the DALC surgery. Because if the patients, we gave them options of C3R, but if they were not fitting it into the the C3R category, then we were giving them, they had to undergo the DALC procedure.
Patients in whom you had DM perforation, were those cases converted to PK or they
Ma'am,
were?
few patients we converted to PK, like 6 patients we converted to PK, but in those where only tiny DM perforation was there, and we tried for rebubbling or other
Was the incidence of cataract more in patients who had DM perforation intra-op?
like 5 patients we saw, 5 patients had DM perforation, had cataract as the post-op complication.
What could have been the cause for glaucoma, secondary glaucoma in these cases?
Mainly because of pigment dispersion, the trabecular meshwork would have blocked, and that can be one of the cause for the glaucoma in the patients.
What is the protocol you followed for VKC patients? I mean, how did you treat VKC in these patients before
If
taking them for DALC or PK or whatever?
If the patient had VKC, active VKC, we were treating them with the steroids or any immunosuppressants.
Topical?
Topical, sir.
Okay.
Yeah. And we were, until and unless if we are taking off the steroids and still the VKC is like inactive, then only we will transfer that patient to
How
the.
long you say?
So
it is
minimum for
inactive?
1.5 month we did.
1.5 month of inactivity of VKC. That's
Inactivity
what
of
you mean to
VKC,
say.
yeah.
And you mentioned that some of your VKC patients, more of your VKC patients had vascularization. So when they developed vascularization, did it change your line of management, or did you add some systemic immunosuppression, immunomodulators, maybe cyclosporin or anything? Was it
so-
added?
Yeah, we added steroids, sir, for oral Visalon steroids according to
That
the.
is for temporary purpose, but
Temporary.
once the vascularization is initiated, so did you think of adding any immunomodulator like oral cyclosporin, or it was not added in this study?
No, sir, in our study, we did not added any oral immunosuppressants. Either we were giving them topical immunosuppressants like
No, I am asking, once you have suppressed the VKC with topical medications, then you did DALC, and then you are noticing that now the deep vascularization is coming up, right?
Yeah, sir.
Now, do you think that we need to add systemic immunosuppression, or we need to continue on the drops which we have been giving before?
So like in our study, we did not started topical
Okay.
like oral immunosuppressant for the patients.
You did not start.
You did not
Okay,
start.
and one more thing, what were the common clinical presentation in cases with rejection?
So like stromal edema will be there,
Okay,
sir.
did you notice any interface fluid in these patients?
Interface vascular,
Interface fluid?
interface fluid, no,
No.
No,
Okay, in rejection cases, did
No,
you look
no.
for it?
no, sir, we did not like.
Yeah, you didn't look for
we
it,
did
right?
not look for
Yeah,
it.
so if you study these patients of DALC with rejection in pediatric age group, most of them have interface fluid, and
Okay.
sometimes it is vascularization with interface fluid is sometimes indication of rejection, which you might consider just as a vascularization, which you mentioned as vascularization. So they might be having some interface fluid, and they might be at early stage of rejection. So that's why I suggested that in case you notice the vascularization, and if you look at the interface properly, or earlier sign of deep vascularization, I think you should shift to systemic immunosuppression, at least in patients with VKC, at least systemic immunomodulator like cyclosporin or anything.
Okay, sir.
Yeah.
Okay, sir. Thank you.
Dr. Shalini Singh? Is she there? Dr. Shalini, you'll present your paper again for semi-final?
A very good afternoon, everyone. I, Shalini Singh, shall be presenting DSEC graft rejection, a retrospective study of demographic profile, clinical characteristics, and outcomes. So, as we all know, the most popular technique for posterior lamellar keratoplasty today are DSEC and DMEC. In a recent study conducted in US, the number of cases which underwent DSEC was 20,000 and DMEC 7,000, indicating DSEC is the most popular posterior lamellar keratoplasty, especially in eyes with complex anterior segment anatomy. Hence, anything which compromises the outcomes of DSEC is very important to be understood. In a study published by Das et al., corneal edema post-cataract surgery was the most common indication for DSEC at a tertiary care facility in South India, followed by endothelial dystrophy and failed grafts. So coming to our study, the purpose of this study was to evaluate the demographic profile, clinical characteristics, and outcomes of DSEC graft rejection at a tertiary eye care facility. It was a retrospective analysis of patients diagnosed with DSEC graft rejection from May 2012 to February 2019. 61 eyes of 61 patients were included, out of which 6 patients did not follow up after the first episode of rejection, hence were dropped out of the study. A standard DSEC surgical technique followed was pre-cut eye bank prepared tissues were used, where a donor size of 8 to 8.5 millimeter and the DSEC lenticule was inserted inside the anterior chamber with sheaths glide. Postoperative management consisted of topical broad-spectrum antibiotic and steroids, which were gradually tapered and maintained at once or twice daily. Shifting our gaze to the results obtained in this study, the mean age group in our study was 52.44 with a range from 12 to 83 years. Coming to gender, females were 31.48% and male 68.52.
Laterality, there was no significant difference in the right and the left eye. Indication of DSEC for graft rejection, prior failed graft, including both post-penetrating keratoplasty and endothelial keratoplasty, was the most common indication, and one of the significant findings noticed in our study was post-inflammation, that is toxic and viral endothelitis, and iridocorneal endothelial syndrome had a high proportion of graft rejection. Coexisting parameters and comorbidities was noticed in 64.81% proportion of patients, among which secondary glaucoma was the most common ocular comorbidity reported. Clinical factors of DSEC graft rejection. According to the study published by Price et al., endothelial immune response post-DSEC graft rejection is so subtle that most of the patients in their study were picked up on routine examination. On the contrary, most of our patients presented to us with complaints of pain or photophobia, and clinical feature diffuse corneal edema was the most common feature reported, followed by keratic precipitates. Diffuse corneal edema with KPs, sectoral edema, keratic precipitate, and one patient presented with AC reaction with a streak hypopyon. Time since surgery, most of our patients presented with graft rejection between 6 months to 1 year. Now, graft recovery in our study subjects, 31.48% of our patients did not recover after the first episode, 46% patients recovered completely, and 22% had a partial recovery. So after this, we did a risk factor analysis for non-recovery among the patients, in which we noticed that patients who presented before 7 days of graft rejection had better outcomes and better chance of recovery. The number of transplants done before did not have a significant effect on recovery post-rejection. IV methyl prednisolone also did not have a significant role in graft recovery. Using topical steroids when complaints started also did not have a significant impact on graft recovery among this subgroup of patients. Endothelial cell loss after rejection. This is a clinical photograph of one of our patients which shows that endothelial cell loss after graft rejection episode was almost 50%. So when a mean data was calculated, most of the patients had a mean cell loss of 38.87%. So to conclude, the factors which influenced recovery according to our study was young age, poor visual acuity at presentation, and late presentation, that is after 7 days. When we compare to the findings of our study with the studies reported earlier, our study had a younger age group, that is 52.44. Indication of DSEC most common for graft rejection was failed graft. Ocular comorbidities, as seen from this table, it is similar to what was reported in other studies, that is secondary glaucoma was the most common association. Time point of first rejection was also almost similar to other studies reported between 3 to 12 months. Thank you.
What is the standard protocol for management of graft rejection at your institute?
So ma'am, actually in these patients, some of the, like after DSEC graft rejection, in the earlier years till 2012 to 2014, there was administration of IV methyl prednisolone in patients who had like hyperacute graft rejection with significant edema. But after 2014, we have not been giving oral or IV methyl prednisolone. It has been only topical steroids and cycloplegic.
What about triamcinolone acetate injections, either subtenons or
No ma'am,
you do not?
we do not give, like for any of the graft rejections, I have never seen being given it.
And oral steroids?
Oral steroids also no ma'am.
How many cases of HSV were there in this group, subgroup?
6 patients, sir.
6 patients. So, how did you differentiate between the recurrence of HSV endothelitis and the rejection?
So, sir, if it is recurrence of HSV endothelitis, then there should be involvement of both graft and the host.
Right.
And in case of graft rejection, it is mostly the graft, the graft which is involved. The edema is more restricted to the graft DSEC lenticule, and the pigments or the keratic precipitates is also restricted to the grafts. But in case of HSV endothelitis, there will be involvement of the host also.
So all these three papers were very nice. It's neck to neck competition, very well presented and very good material of research also. So congratulations all three of you and keep doing well in future. Thank you all and thank you all for listening. Thanks to my colleagues for this. So we end this session with this presentation. Thank you.